was born by the river in a little tent. Like the river I've been running ever since. It's been a long time coming, but I know change gonna come. Oh yes it will. It's been too hard living, but I'm afraid to die.
Welcome to Exploring Culturally Fluent Healthcare, the 11th program in an ongoing series to encourage understanding and discussion about the legacy of race and ethnicity in America, and how together we can make changes for a more just future. Before we get started, I'd like to thank our many community partners, the National Endowment for the Humanities and More Perfect Union Initiative, and sponsors, the Durango Herald, Ground Floor Media, and the Center Table, Tate Law, the Araflo Libraries. I'd also like to recognize the Colorado Humanities Board of Directors and staff on our Changing the Legacy of Race and Ethnicity Committee. And a special thank you to Colorado Humanities staff, Lanaya Butler, Josephine Jones, and Executive Director Maggie Koval for their commitment in delivering this important programming. It is now my pleasure to introduce the moderator for this panel, Dr. Lesley Brooks. She serves as the Assistant Medical Director for the North Colorado Health Alliance and as SummitStone Health Partners Chief Medical Officer. And she leads in the design and development of Larimer County's new Longview Behavioral Health Services facility that is set to open in November 2023. A board-certified family medicine and addiction medicine physician, Dr. Brooks practiced full-scope family medicine in Northern Colorado for more than 12 years, including prenatal care, chronic pain, mental health, and substance use disorder addiction. Since her transition to SummitStone Health Partners in 2020, she specializes in substance use and mental health. Without further ado, Dr. Brooks, please take it away.
Thank you so much, Christina, for that, those kind words and for that lovely introduction. And thank you to all of you for joining Colorado Humanities and our panel this evening for an important and critical dialogue about culturally fluent healthcare. I think we all recognize that change begins with connection, with dialogue that begins in small spaces and grows into bigger and bigger spaces. And most importantly, with dialogue that grows into action and change. This talk joins the many that Colorado Humanities have hosted on equity, educators and workforce transformation, policing in communities of color, whites and racial justice, faith and equity, and how to talk with children about race. And I am so honored to participate and facilitate this conversation on exploring culturally fluent healthcare as an addition to this important catalog of conversations. So let's get started. I'd like first to allow my panelists to introduce themselves and talk just a little bit about their work. Dr. McNeil-Miller.
Good evening, everyone. I'm Karen McNeil-Miller, and I'm President and CEO of the Colorado Health Foundation, based in Denver. We are a statewide foundation, and we are trying to bring health and reach for Coloradans who are living with low income, who are marginalized, who have existed with little power or privilege, and we prioritize communities of color, Coloradans of color. And I will say that I get the question all the time, why do you focus on race when there's so many other intersectionalities? You know, there's disparity and inequity in, women and girls, and children, and LGBTQ, and disability. And I say, yes, all those things are true. And in all of those groups that you just mentioned, when you dig deep and look at the data, the greatest inequities and the poorest health outcomes are amongst people of color. So the worst health outcomes for women are amongst women of color. For children, children of color. For LGBTQ, LGBTQ of color. For rural folks of color. So there is a centrality of race that we have to address. So if we really want to address the deepest inequities and the place where there's the most disproportionate negative impact to a group of people, you would start with race, and that is what we do.
Thank you. Dr. Reddy.
I'm Sarita Reddy. I'm the Executive Director of Adeo, Colorado. We are a nonprofit organization that's been around in this community for over 40 years, and we support people with disabilities in a variety of ways. The core of what we do is provide residential supports to people with brain injuries, adults with brain injuries. And it is the place where we were one of the first pilot programs in Colorado. There were 4, we're one of the 4. And to date, 20 years later, there are no other agencies that provide those kinds of services in northern Colorado. There have been others that have started up in Denver and so on, but nothing in northern Colorado. So that's our niche. We claim it proudly. We do it really well. And so that's a brief intro to what I do.
Thank you, Dr. Reddy. Dr. Longenecker.
Hello, I'm Beth Longenecker. I'm a rather newcomer to Colorado. I've been in Colorado for 6 months. I'm the founding dean for the new Osteopathic Medical College that we're building at the University of Northern Colorado. The impetus behind this is to address the physician shortage that we currently have in Colorado and the impending increase in that shortage of physicians. My background is I'm an emergency medicine physician, board certified. I've worked in multiple safety net hospitals. I was the residency program director in the South Bronx at one of the programs. And I truly have wanted to address health inequity throughout my career in both my role as a residency program director and as well as working in rural medicine. When I was in Ohio, I was the medical director for our community health program. So we serve 27 rural counties in southeastern Ohio.
So with that and this incredible panel, let's get started. It seems appropriate to name things as we begin to talk about health equity and about the legacy of race and ethnicity. So I wonder if we might start there. If we might first consider the idea of changing the legacy of race and ethnicity in the context of healthcare. I wonder if each of you would please share with the audience your perspective on this legacy of race and ethnicity as it relates to your work. What is this legacy that we have to contend with? What is it that we are talking about when we use these words, the legacy of race and ethnicity? How do the vestiges of this legacy show up in your work in healthcare? And I wonder if I might begin with you, Dr. Longenecker. What do institutional structural inequities and the legacy of race and ethnicity, what does that look like in medical education and residency training?
Well, to begin with, I think that you need to go back to what Dr. McNeil-Miller was speaking about, that race is a bottom line issue in health equity and health outcomes. If you look at the history of health policy and medical care in the United States, everything from the way insurance access has been legislated to the compensation for care in underserved communities, to things that amplify those physician shortages in those regions because of those financial concerns, and segregation of communities with the development of food deserts, life stressors, inability to access care. We're seeing a significant disparity in the outcomes in the Black and brown community. That's everything from screening tests for cancers to outcomes after stroke. There's even a recent article that came out that looked at worsening outcomes in Black patients in nursing home facilities because of those similar aspects of staffing and under-financed institutions. So if you look at that inequity is also compounded and reflected in the physician population. At the moment, only 5% of all practicing physicians are Black, and only 6% are Latino Hispanic. So when we look at that, that's also part of our structural and race, the structural racism that we face. Everything from our tax basis for our public school systems, the lack of access to AP classes and advanced learning, the lack of access to pre-health advisors for students who are in these underrepresented communities. That then leads to a decrease in the pipeline of students who want to become physicians. So as a medical educator, we've been slow on the uptake. When you look at medicine and discussion of racial inequity, for the longest time it was all based on, well, it's genetic or it's life choices, and it's only since 2014 that we've really begun to recognize that this is really tied to social determinants of health, things within the community, things within access, things that could be changed, but it requires public policy, and it's not an individual choice of our patients. So we're a little slow on the uptake on this, and we really haven't called out institutional racism until 1920 as a group in medical education. The good thing is, on a more hopeful note, this is really generating an impetus for change. Not only to advocate for policy change, but also to look at how we recruit and train our next generation of physicians, and how we actually educate our current generation of physicians about these aspects of healthcare and the importance that this actually has on the impact and health outcomes for all of our patients.
So there are about 95 threads in there that I want to pull on. But we're going to keep going. Dr. McNeil-Miller, what do institutional and structural inequities and the legacy of race and ethnicity, what does that look like in the world of philanthropy and funding?
So, for us, just to tag on, it's access to care, it's access to culturally competent care, to culturally humble care, and the legacy, the historic legacy of healthcare using people of color as guinea pigs. And so healthcare has become one of those systems that communities of color don't trust. Along with the system of education, along with the system of law enforcement, along with the system of, criminal justice, criminal legal reform. And to the point about some of that legacy, I've just been reading some emerging data that challenges what we've all been taught, has been a mantra for decades, which is that the presence of HDL, high HDL, the presence of good cholesterol is a key factor in mitigating heart disease. Well, now the data are coming out, well, that's not particularly true in African Americans and Latinx populations, and that the presence of good cholesterol isn't a predictor of better heart health. And why is that? Because all the research was done on who?
Yeah.
White folks, right? And so there's kind of the different historical genetic makeup that's taken into consideration. So how many of those things have we been taught? How many the unconscious biases of care we care about in philanthropy? That it's assumptions that the physicians may make that, well, if I tell them they're going to diet, if I tell the brown person to go on a diet, they won't do it, but they will take the medicine. Whereas if I tell a white person to go to get exercise, they'll comply. And so those kind of decisions that are made. So we focus on those kind of things, and in particular, access to care, and certainly in the non-documented community, really access to care is a strong issue in philanthropy.
Thank you so much for each of your perspectives. Now let's pull on some of those things. One of the things that we've been talking about this evening, and as well as others that we haven't mentioned, we certainly haven't mentioned the catalog of things that rise to the level of critical health equity challenges. But I wonder if you would each name your top two most important and critical health equity challenges that need to be addressed today. Dealer's choice. Dr. Reddy.
Okay. Behavioral health rises to the top. Access to behavioral health. And I'm here today speaking about the population of folks that we support, people with brain injuries. And they come with a very, very complex constellation of needs, physical health needs, behavioral health needs, and all of that. And behavioral health is impossible to find. It's impossible to find providers, and when we do find providers, how do I put this? They're less than stellar and often do not really listen and do not really take into account the fact that there's a lot going on with this person. And if we can find people that are willing to do medication, we certainly can't find people who are willing to talk and try to unpack what is happening with this person who's undergone so much trauma in their lives before they've landed where we are, receiving services from an organization like ours. So that's one of the top things that I find is really, really tough. And it's not just for people with brain injury. I had a personal experience too, my first interaction with the mental health system, and I could not find anyone. If I didn't have a friend who could prescribe for me, I would have been up the creek without a paddle. And so I think that's one of the top things. The other thing that I will say in terms of just something that leads to just less than stellar care in general for the people we serve is the fact that healthcare seems to be so siloed now. We use terms like medical home. Everybody has to have a medical home. What does that even mean? Because you might have a primary care physician and it's in the system that this person is your primary care physician. That person doesn't necessarily know you real well. And if you're the kind of person that's seeing a number of specialists and behavioral health folks, there's no talking amongst those folks. And again, part of it is the way the system is set up. People seem too busy, there's not enough time to talk. And that seems to be a huge piece of it. There's, it's fine if we can run tests and diagnose something. But if it's more than that, it becomes really, really hard. And for the people we serve, for whom communication is already an issue, this is really, really terrible.
And I think there's some synergy between what you were raising, Dr. Reddy, and what Dr. Longenecker was raising around policy. It's like what our systems are incentivized by what they get paid to do.
Exactly.
And we are most robustly
Yes.
reimbursed for the doing, for the diagnosis, for the cutting and the snipping and the treating and the prescribing. Less robustly reimbursed for the talking.
Yes.
And the therapy. Dr. Longenecker, I wonder if he would talk a little, and that's a policy issue that Dr. Longenecker raised. What about you? Your top two most important and critical health equity challenges that need to be addressed?
My top two, no, both of these are the heavy lifts.
Okay.
One is changing the culture of medicine so that we actually incorporate a holistic view of our patients. Because if we truly wish to take care of our patients across any dynamic, any race, any issues, we need to understand where they're coming from, what their issues are, and truly work with them to enhance their care. And the only way to do that, frankly, is through education. We need to teach our current physicians how to use that approach and how do we actually have a sensitive conversation about what does your patient really want and what assumptions you may be bringing to the table so that you don't put your assumptions onto your patient. We need to do that as we develop our curriculum for future physicians as well. And the other is to increase our diversity in the workforce. I mean, really, it's criminal that we have a 5% African American population in practicing physicians. We really need to find ways to create those pipelines, create the resourcing that we can support the next generation of physicians and grow that. I'm really excited to be here where we have so many Hispanic students at UNC because I think that's a great way for us to start those conversations and go back and create those pipelines all the way back through the 5th grade and 4th grade on.
And what an opportunity we have in Greeley, in northern Colorado, with our new Adeo school to really change the conversation and lead the narrative about how you do that. We're going to pull on some of those threads again here in a minute. Dr. McNeil-Miller.
I was also going to say more patient-centric rather than provider-centric care.
Yes.
Since you said that, I'll get to it. Certainly more representation of people of color in the clinical setting across the full spectrum of clinicians. And then I also want to just go a little bit deeper into the behavioral health piece. And I don't know if this is a training or life experience issue, but just a recognition of what the trauma that just living in a society that is fundamentally built on racist principles, the trauma and stress that creates in the human body that leads to behavioral health issues that people don't even recognize, but that also lead to medical issues. If life is just so tough, you forget to, you're just so tired, you become more sedentary. Or you are if you're so worried about being able to provide a roof over your family's head or food for your family, then, getting your, flossing gets way all down the list of things you have the privilege of worrying about. So it's just understanding all the stressors that life is created on people of color by virtue of being people of color in this society, and how things that we have the luxury of caring about get further and further and further and further down the list.
Worrying about your children at school. Are they safe? Are their behaviors being interpreted appropriately?
In school, on the plane, anywhere.
Come again?
In school, on the plane, anywhere.
Right.
Yes, absolutely, absolutely. Okay, let's continue to delve deeply into these issues. I wonder if each of you would talk about the work that you are doing and your organizations are doing to respond to these inequities. What steps are being taken in your organizations to dismantle or reassemble the building blocks of healthcare such that equity is centered?
I'll go first if you don't mind, because I kind of wanted to just make the point that, even though we sit as an organization in the healthcare space, we're funded by Medicaid and Medicare and those kinds of things, but we're not really just healthcare. We support people to live full, meaningful lives, and good health is a huge and critical part of it. It is not the only thing that we do. And I want to just say that, in the healthcare realm, we are considered unskilled. We do not provide skilled care, right? We just help people get up and face the day. We help people, form new relationships. We help people hang on to the relationships that were important to them in their past. We do all of those things, but we are unskilled. So I just want to lay that out there and say this is also one of the issues that is very, very, very present in the way healthcare language works and things like that for those of us that are in this in-between space. And, like Karen said about the social determinants of health, this is what we work on. We work on the social determinants of health, and yet it is considered unskilled. And so for us, one of the things that I have been doing, so our structure is built on the backs, as many healthcare entities are, of the direct care workers, people who are on the front lines, people who are with the people we support day in and day out, right? And they tend to be disproportionately women, they tend to be mothers, they tend to be often women of color, and one of the things that you don't find as much in the upper echelons of these organizations is people of color. And so one of the things we have done is very intentionally recruited people of color, people from the LGBTQ community, people from very diverse backgrounds, because we want representation within our organization. And so that's one of the things that we've been doing. And it's important for our direct care staff to see themselves reflected in the leadership of the organization, so that they can feel heard, they can feel seen and understood. And by virtue of that, they're able to also then take care of the people who rely on them on a day-to-day basis. Because I think, people in healthcare, people who work, if they don't take care of themselves and they don't feel heard and seen and valued, they cannot bring their best selves to work. And that means the people we serve are not going to be well served. So that's one of the things that we've been doing. So we've done that in a number of different ways. Just looking at our recruitment. Where do we recruit from? Where do we pull people from? What are our criteria? If we can train for the job, do we need an academic credential of any kind? Probably not. We can probably just ask you if you can read and write, and that's it. And so that's what we've done. We've pulled apart all of that. We've pulled apart criminal history, because it can mean all kinds of things for all kinds of different people. Two people could have had the same kind of encounter with the law enforcement, could be entirely different histories there. And so we've removed all of those standard kinds of barriers to entry into the field. And then the other thing that we're doing, back to workforce shortage, it's not just in physicians and things, it's also nurses. And I know Lesley put together just a laundry list of people who work in healthcare, and there's a shortage across all realms of healthcare, including direct care professionals. And so we are working right now, we've stepped into the workforce development arena so that we can work with the school district here to pull students, particularly students of color, and bring them into the fold to expose them to what it is we do, so they can get a a close view of what the work is and the joy that it can bring and the fulfillment that it can bring, that kind of thing. But we're also then pulling from our staff women of color to serve as mentors to these young people so that they have a career pathway, which is something that's non-existent for direct care professionals right now. And so we're working on those kinds of things as well. I'll stop now because I can go on and on and on.
Fantastic. So I'm hearing deliberate recruitment, I'm hearing ban the box, and let's identify the right candidate and then talk about whether or not there's a criminal background, workforce development, and mentoring. And I'm also hearing sort of a signposting around, because unskilled means something. Unskilled means something about reimbursement. Unskilled means something about the value that we put on that workforce.
Yeah. Well, we certainly have broadened the definition of health beyond health care, beyond access to clinicians, and beyond healthy eating, active living, to include some of those social determinants. I have to, with this audience, I can talk about social determinants, but I don't know any low-income folks who've ever uttered the phrase social determinants of health.
Let the church.
But they talk about it all the time. They talk about it in the form of just can't seem to get ahead. Got more bills than money. They talk about it all the time. They just don't use that language. So we are, in addition to primary care and access to, healthy eating, and particularly children's movement, we also have prioritized 3 of those social determinants. One is housing affordability, one is food access and food justice, and the third is economic mobility, which is to try to help families earn a wage, through policy, to practice, earn a wage to where they can care for their families. So, we know there's a direct correlation between income and health outcomes, because you have more choices, you can move closer to a physician, all kinds of things. So we spent a lot of time focusing on that. Nationwide in philanthropy, less than 6% of philanthropic dollars across the country go to BIPOC-serving, BIPOC-centered organizations.
6%.
Less than 6%. So we're trying to change that for us in Colorado. So we are committed to at least 25% of our funding goes to BIPOC-led, BIPOC-centered organizations. And then at least half of our funding goes to organizations who serve at least 50% BIPOC. So we're trying to change that, because that's another source of inequity, of who's been trusted with the money, who can we trust to spend this money. And so I've seen us spend 30 minutes talking about whether to give this little organization $75,000 that we know they know how to rub 2 nickels together and get a quarter, and that $75,000 they'll do $500,000 worth of work, but we don't even blink an eye at a $5 million grant request from the university. So we try to flip our script on, so which of those is the riskier? Which of those is the riskier investment? So we're trying to do that. The last thing, we're also engaged in workforce development, particularly in rural communities, kind of a grow your own, because we participate in the loan repayment program for primary care physicians, those who will go to rural communities, hoping that if they go there and they stay 2 or 3 years, they'll get some roots, they'll start a family, they'll start liking it, they might stay. And then the last thing I will say about recruitment, although I still believe one of the big issues is lack of diversity amongst clinicians. I have in the past 2 years had BIPOC clinicians really cause me some cognitive dissonance, because they've said to me, why are we always the one expected to go to the underserved community where the people are sicker, the hours are longer, the pay is lower? Why am I not allowed to start a what do you do when you have plastic surgery? Why am I not allowed to have cushy plastic surgery on Rodeo Drive? Why do you don't allow me to do that? And so that's causing me some cognitive dissonance.
Just in terms of why that isn't okay.
Right, yeah.
I just wanna pause here for just a second. And I was recently a part of a conversation. Sarita and I were recently a part of a conversation where our committee was asked to evaluate a workforce development grant. And and I wonder if you would talk about this just a little bit and talk about how the Colorado Health Foundation has evolved this. One of the pieces of feedback that our group was able to give the workforce development arm of the county, as part of this grant, the grant required them to assess applicants in terms of risk. High risk, moderate risk, and low risk. And part of the feedback that our group gave was that assessment is marginalizing.
Right.
And is there a way, we really asked, is there another way for you to describe these organizations and characterize these organizations? Can you
And
comment
what does
on
that? And what does it look like in practice?
Yes.
Yeah.
Does that mean if you went to Howard Medical School, you automatically, the highest you can get is medium risk? Or if you go to Harvard Medical School, you start at high risk and it's yours. High risk is yours to lose, whereas in some other, for lots of people of color, not high risk,
low risk.
Low risk is yours to lose, whereas if you're a person of color, low risk is yours to earn. And that in and of itself is a disparate and equitable system. And so changing those to change, I think going in, having an equity, inclusive mind is a mindset, first and foremost, a mindset shift. And then there's behaviors and practices. But it first has to be a mindset shift.
Thank you for that. Dr. Longenecker.
So I'm in the unique position of we're a new organization and we have a chance to actually create something with intentionality. So we can actually sit here and say these are the issues we're seeing in health inequities and racial inequities in the healthcare system. How do we intentionally create our curriculum, our hiring practice with DEI in mind? How do we develop those mentorship programs now so when our students are here, they have those folks that they can talk to, that they can actually express what it feels like to be a physician of color? How do we actually look at our admissions policies to make them more holistic? It's not you need to have, in the top 20th percentile on your MCAT. You need to have an MCAT that's going to demonstrate you can do the coursework. And then the other things come into play. How do we create those pipeline programming where we reach out to the 5th graders and 6th graders and talk to them about healthcare and collaborate with our School of Nursing and our other health professionals and say, here are things you can think about, and give them those opportunities for mentorship and those opportunities where even if your school system doesn't have AP programming, we have counselors who can talk to you about what are the other ways that you can achieve some of those benchmarks that'll help you succeed in what you want to do in healthcare. So it's a really exciting place to be, and it's a great place to be reaching out to folks who have a background in how do I develop these programs. It's a great place to be to say, how do we actually develop that pipeline and what would really need to be in place to support our students, because I am not looking to pull the Harvard students that have the highest MCATs, highest grade point average. I'm looking to pull the students who have the tools that they can succeed and they truly want to serve in Colorado, serve in the rural population, serve in the area, and then create those support structures for them so that they can succeed and do so.
Awesome. Thank you so much. I appreciate that. Okay, we're gonna keep going here, and I'm trying to decide and manage our time. Where do we go? Where do we go next? How about partnership and collaboration? I'd like to talk about that in a moment. I'd like to say that uncommon relationships are key to solving some of our most important challenges in healthcare delivery, in wellness, to our point that this is about more than just healthcare. We in the health business, you reminded us many years ago when you came that healthcare is everybody's business. Must be in dialogue with and you also mentioned this earlier, the criminal legal system, with our first responders, with our education system, with our Department of Human Services, with our child welfare system. What are the uncommon relationships, if any, that you see as critical to the evolution of equitable healthcare delivery? What relationships are you cultivating? Who would like to start?
Well, I think we all have said in one way or the other, the most critical partnership that doesn't necessarily exist now is the patient-provider partnership. We would love to see that partnership take center stage. But we are partnering, with developers, for housing. We're partnering with the organizations that are really more in line with the social determinants to try to create change. The group we have not been able to establish strong partnership with that I would love to is the faith community. I talked about institutions that people of color don't trust. Well, I think the only one left that they trust is their faith community. And I think that faith community is key to informing folks. We have not been successful with that. I would love to do that. One that we are particularly proud of is we have always had a partnership with the state. And part of that is uncoupling some things. And frankly, saying that we're not your ATM. We're not your ATM machine. But where is it that we can help you? We can't supplant government funds, but we can help you design equitable processes. And that's a partnership that we're excited about. This administration and the former administration was very open to that partnership, because the way money gets funneled through the state government now to organizations, those BIPOC-led, BIPOC-serving small organizations aren't included. They don't get the announcement. It's burdensome. The application, the paperwork is burdensome. They get amounts that are not worth the, not the paperwork. So that partnership, I hope will bear some fruit.
That's wonderful. Thank you.
So for me, partnerships, there are partnerships on two levels, I guess. With work, when I center the people we support in my thinking, I'm always looking to partner with anyone who can add to the quality of life of the people we support. How can we elevate lives? That's our mission, is to elevate lives. And so I just exchanged cards with Christina as soon as I found out who she was and what she did. I said, we got to talk. And so I'm constantly looking for different kinds of partnerships, because for us, the work we do is to ensure that access to community the barriers to access to community is removed. Those are the barriers we're working on. So everything to do with community, whether it's healthcare or not, which it all leads to health, good health or not. And so we have partnerships with all kinds of folks in that sense. On a more personal level, I would say that some of the wonderful partnerships lately have been with, I live in Larimer County, and so working with folks in Larimer County, with people who are in the community, but working with people who live in the community but also work for the county. And there's all these intersections of roles of folks, and all of us are united in that we want Larimer County to be a fabulous place to live for everyone. For everyone. Period. And so that's something that we're working on, and that's been really quite incredible, just finding people who are passionate about this and working alongside them to see how we can advance what we all want as members of the community.
Fantastic. Thank you.
I think when we think about uncommon relationships in the medical profession, everyone's talking about interprofessional education. How do doctors and nurses work together? How do we work with therapists and others? But I think what they forget is that medicine is a larger team sport than that. It's not just doctors and nurses and a physical therapist. It's also the social worker who's connecting that patient to their resources. It's navigation programs where you can connect folks to available insurance and other resources. So expanding our relationship and expanding the knowledge of our students as to what is available in the community that they can connect with. Also, one of the faults in many of the medical school programs or programs that you see where we're trying to create resources for our communities is we don't ask the community. We look at a community and say, well, hey, it's obvious they need this or that, when if you actually sit down and talk with the community leaders, the population in that community, they say, you know what, I don't need that. I need a playground where it's safe to send my children. And I think that one of the biggest partnerships we need to look at is, as we do this reach to our rural communities and our other communities where our students are going to be, how do we develop that community relationship, that we build community support structures that the community truly needs and that meet their needs and desires. That's where we're going to see better health outcomes. There's a book that came out many years ago called The Death Gap, and it looks at life expectancy in Chicago along Ogden Avenue. And this is a wonderful internist from the Rush Hospital System who wrote this book. And he actually looks at two communities that are literally across the street from each other, have the similar ethnic makeup, similar educational background, similar cost of, similar earned income. But there was a four-year difference in life expectancy between the two communities, and the difference was infrastructure that was built by the community, within the community, to support things like after-school programs, other things like that. So we can partner with our communities to say, what do you need beyond medical care to address some of these social determinants of health, and then partner to resource them in some way, be it petitioning the government, be it, creating a broader base for a grant, something, then we're going to have a bigger impact on health than if we just go in and dictate, this is what you need.
And pretty powerful to include that kind of energy and effort into medical education. Yes, I need you to understand the Krebs cycle and how the kidney works, but I also need you to understand how parks get built and what are the policy steps of doing that, because it's very relevant to the tools in your toolbox as a provider. Those things are issues of policy, and powerful to be a part of that.
I have an example.
Yes,
It's
please.
exactly what you just said. This happened in North Carolina. We looked at the communities that they need a park or a playground. So we built this, we had community center design, we had the kids and the grandparents design this playground, built this beautiful playground, and then nobody was using it. So we went back and asked them, aren't you using it? They said, there's really nothing wrong with the old playground. It's just, there's a drug deal in every, in all four corners of the playgrounds. We're just not taking our kids out there. It's like, okay. So the intervention that we were able to help to support was having law enforcement put actually a mobile unit in that community. That's what they needed. Yeah. If we had the sense to ask, if we had the sense to ask them that first, we would have saved a lot of money and a lot of their time. They loved the park. But say the last one was okay.
And we have the same kind of thing, because Dr. Brooks and I have talked about this before. We provide services in a particular kind of way because we're licensed in a particular kind of way, and our funding comes through in a particular kind of way, and that's all we're funded to do. But all of this was developed for white folks, for that particular kind of, it was all learned on that culture. And so when, we've had this experience with this one Latino family, and as much as we want them to come and we want Andy to live with us, no, it's not going to happen. It is not going to happen. And so we've got, one of the things that, we have talked about as staff is, how do we find out? We've got to find out what it is they need, because they need it. He needs a lot of support. Mom is getting older. All of those things that stay true for a family of any ethnicity hold true for this family too. But mom isn't gonna come to us. Why? She was fine with it. If he could just come for the day, but certainly not to live with us. And so it's really fascinating to me, and I think we have so much work to do. And I think part of it is putting our Latino staff front and center. I don't need to be the one carrying the message, or Courtney doesn't need to be the one carrying the message. It needs to be Sandra and Brenda the ones who can speak and be culturally fluent, not learn to be, but be culturally fluent, and get certain things that would be harder for me to get. It would be harder for some of the other staff on my team to get. And so, yeah, I think that's a huge piece. I mean, we have to recognize that what we have built, even if it's wonderful, isn't wonderful for everyone.
Dr. Kamara Jones, who is a family doc and a public health practitioner, and just a giant in the field of health equity, talks about what, I'm not going to do it justice, but talks about who sees an open sign and who sees a closed sign. And how do you signal? There are many ways besides a sign to signal whether or not that door is open or closed to you. And part of how we do that is with our workforce. Part of how we do that is how the front door is structured. Part of how we do that is policy. And oh boy, so many questions from this incredible panel that I really want to pull on. But before we move on, I want to ask Dr. McNeil-Miller about the faith community, because I think that there are many who want to partner with our faith community and who also struggle. I wonder if you might just talk a little bit about what those barriers are and what you think the road to success looks like.
Well, in many instances, it's the orthodoxy and the actual belief system of the faith community that itself is a barrier. So, there are faith communities who would not support the full range of reproductive services up to and including abortion. I've had conversations with several pastors about, I need you on the mental health bandwagon. You look out every Sunday or how many every days, and you know which families are struggling with sex abuse or child abuse. You know which families have addiction. And you got to do more than rub some oil on their forehead, right? So, can you partner with, can you do that and send them, help them to get, promote some resources? So some of it is just their own orthodoxy.
Understood. I wonder, I want this incredible panel to talk just a little bit about policy. I recently attended the Colorado Health Institute Policy Conference, and in the opening session, the speakers talked about 3 ingredients for change in the health policy space: the state having an obligation to address a concern, funding or resources to do the work, and having motivated partners who want to fix this together. I wonder if each of you could share your perspective on these 3 ingredients. Where are we the strongest and why? Where do we need more work and why? And most importantly, what opportunities do you see for policy change to improve wellness and thriving to address institutional and structural inequalities? Where are we strongest and why? Where do we need more work and why? What are the opportunities for policy change to achieve wellness and thriving?
If we could get rid of employer-funded health insurance, that would be a huge start.
Half hour on that one, give me a half hour.
That's set up a lot of the inequities that we see.
It absolutely has. If you have to have a job in order to get to see a doctor, that is ridiculous.
So unpack that a little bit more, Sarita. What does that mean?
It means that if we could have, universal health care, so that you could go see a doctor when you needed to go see a doctor, and you do not have to think about what kind of plan you have and what, how much it's going to cost and all of that. And if you could be in a situation where coverage is automatic and you're not thinking about, well, if I make this much money, can I afford to cover myself and my spouse and then maybe my children or not, and if not, then what happens then? And are we going to have to then pick between an illness and rent or transportation or whatever it is? I mean, those are all fundamental things, and to have to pick and choose, I think, is just terrible. And for employers, we struggle. At Adeo, we've absorbed the increasing costs for the last 6 years. We've not passed them on to our staff. I have no idea how long we can keep doing it. We'll do it as long as we can, but how long can we do it?
It's not sustainable.
It's not sustainable.
So I think that's part of the mindset issue, which is part of the, the myth of America as the place where you manifest your own destiny. And if you just work harder, if those people would just work harder, if those people would just stop having so many babies, if those people would just fill in the blank, that their lives too could be wonderful and full. Right, look at me. And that, the myth that you can do it without somebody else's help. I don't know anybody that does anything without somebody else's help, influence, support, guidance, grounding. So there's that mindset myth we have as Americans. It's very uniquely Western, and the mindset shift has to happen before the policy will happen.
We won't change the policy unless we tell ourselves a different story about why we need the policy. Thank you. Dr. Longenecker.
I'm relatively new to the state, but in 6 months I will say, I think the thing that we do well is we have significant collaboration across multiple different entities and multiple groups that are addressing similar problems. So I think that collaborative effort in gathering a faction of individuals from varying backgrounds to address these issues is strong. Don't really know about the budgeting process yet, but no matter what in health policy, funding is always the last issue to fall, and it is always the most difficult to overcome. Because where am I getting that money, and where do you recommend I get that money from, and how do we take it from here and not impact X? So I think that if I'm thinking about anything that's broad that we need to impact, it is going to have to be impact how we have affordable and quality health care for the entire state. And that does require change in both mindset and policy and support.
I could talk to these incredible women all night long, but it is the time in our program for us to turn the questions to our audience and ask if anyone has any questions. Yes, sir.
You mentioned the societal issues of how we limit what we can do. We also have institutions. So my question to you each is, if you could be in charge for one day and do whatever you damn well please, what institutional change would you implement that could raise votes for everybody?
What institutional change would we each institute that would raise the rising tide for everyone?
So I'll start that answer with, I had a grantee once. I talked about, rising tide, raise all boats, and they said, "You're assuming we all have a seaworthy vessel." And that some of that seaworthy vessel is in the environmental. I would fix schools first. That's an institution I would wave my magic wand on.
It's hard for me to think of one thing. I just feel like everything is so interconnected. And so again, I think I'll piggyback on Dr. McNeil-Miller's answer and say that young people, start there. Wave a magic wand to ensure that they all grow up valuing each other and everyone around them, and then perhaps we have a shot.
And being valued.
Yeah.
And I would agree that where does that implement that begins as early as preschool and even before. So how do we impact? And the educational system is really one of the highest inequities I think that we see. everything is so focused on income base and tax base right now. If we could reformat how we distribute the finances to our educational institutions to make it more equitable, I think we would stand a chance of starting to make a dent in things and creating that environment where everyone realizes I can learn. Not everyone is going to be a scientist, a physician, but everyone realizes I can learn, I can grow, and that allows you to actually grow internally as well as open those dialogues with others so that you can grow and learn from each other. And I would agree, schools are excellent.
I always challenge this notion that we need to get the kids ready for school. I think we need to get the schools ready for the kids.
That is an excellent note to end on. I think we are just about out of time. I want to say thank you so much to Dr. Longenecker, Dr. Reddy, Dr. McNeil-Miller for an incredibly exciting panel this evening and a robust conversation. And I will turn it back over to Christina.
Yes, thank you so much, panelists, and thank you so much, Dr. Brooks, for your incredible help in shaping this very valuable conversation and try to let us understand more about the relationship between healthcare and race. Please email info@coloradohumanities.org for more information. Thank you again to our sponsor and our partners, and thank you for attending our program. And of course, have a good evening. And again, thank you so much.